Welcome to the Funnel Effect.
Thank you. It is really wonderful to be here.
Today we are doing something that I think is going to feel a little different for you. Usually when we do a deep dive, we are pulling a study from the archives, looking for a discovery.
Right, like a new drug or a fancy new device.
Exactly, yeah, something that adds to the medical arsenal. But today we are looking at a study that is arguably way more important because it didn't just add something. It forced doctors to subtract.
It really did. It forced the whole medical community to look in the mirror and ask a very uncomfortable question.
Which is, are we actually hurting the people we are trying to save?
It is the classic medical paradox, right? Sometimes the quote-unquote best treatment on paper turns out to be the enemy of the patient in the real world.
Yeah, and that is exactly what we are deep diving into today. This is a landmark paper from the New England Journal of Medicine, Volume 358, Issue 21, published on May 22, 2008.
The Horizons AMI trial, this is one of those papers that if you talk to interventional cardiologists who were practicing back then, they remember exactly where they were when they read it.
It was a total paradigm shift.
Absolutely a paradigm shift.
So the title of the paper is Bivalirudin during primary PCI in acute myocardial infarction. And before we get into the actual physiology drama, and believe me, there is a lot of drama here, we really need to acknowledge the massive human effort behind this study.
Yeah, this wasn't just some small lab experiment done over a weekend.
Not at all. It was a massive global undertaking. I'm actually going to read the full author list right now because the scale of this collaboration really sets the stage for how serious this whole inquiry was.
Please do. These names represent the titans of cardiology at the time.
Okay, here we go. We have Greg W. Stone, M.D. Bernhard Witzenbichler, M.D. Giulio Guagliumi, M.D. Jan Z. Peruga, M.D., Bruce R. Brody, M.D., Darius Dudik, M.D., Rand Kornowski, M.D., Franz Hartmann, M.D.
It's quite the list.
All right, let me get through the rest. We also have Bernard J. Gersh, M.B., CHBD Phil, Stuart J. Pocock, Ph.D., George Dingus, M.D., Ph.D. S. Chuang, M.D., Ajay J. Kurtain, M.D., Helen Paris, S.C.D., and Roxana Marin, M.D.
It is just an incredible roster of experts.
And when you look at their affiliations, you really see the global nature of this problem. We are talking about Columbia University Medical Center and the Cardiovascular Research Foundation in New York, but also major heart centers all over.
Germany, Italy, Poland, Israel, for the UK. They weren't just testing a drug here. They were stress testing the entire global standard of care for heart attacks.
So let's set the stage for you. We need to transport you into a really high-stakes environment.
Yeah.
We were talking about the emergency room, or more specifically, the catheterization lab.
Yeah.
The cath lab.
Right.
The condition at the center of this deep dive is ST segment elevation myocardial infarction, STEMI.
The big one. The widowmaker.
So let's unpack that for a second. We hear the phrase heart attack all the time, but what is actually happening physically inside the body during a STEMI?
It is a violent, catastrophic event in the plumbing of the heart. Imagine a coronary artery, one of the main fuel lines supplying the heart muscle.
Okay.
Over years, it has built up a plaque. This is a deposit of cholesterol and inflammatory cells, and then suddenly that plaque ruptures, just cracks open.
Like a fissure in a dam.
Exactly like that. And the body perceives this rupture as a wound, like a cut on your skin. So it reacts the only way it knows how. It tries to seal the wound.
It panics, basically.
Total panic. It unleashes the coagulation cascade. Platelets, those tiny sticky blood cells, they swarm the area. Fibrin starts to weave a net.
Right.
And within minutes, you have a thrombus.
Right.
A massive blood clot that completely blocks the artery.
So the fuel line is just cut off,
Yeah, completely occluded, zero blood flow. And the heart muscle downstream, which desperately relies on that oxygen, starts to suffocate.
Wow.
It begins to die immediately. That is actually why we see the ST segment elevation on the ECG. It is the literal electrical signal of the heart muscle screaming for oxygen.
And there is that mantra in cardiology, right, Don?
Yeah.
Is muscle.
Yes. Every single minute that artery remains blocked, you lose more pumping function, and the patient's chance of survival just drops.
So the mission is very clear. You have to open the artery. And by 2008, the medical community knew that the best way to do that was primary PCI.
Oh.
Percutaneous coronary intervention.
Which is essentially angioplasty and stenting. You thread a catheter from the groin all the way up to the heart. You pass a wire right through the clot. You inflate a tiny balloon to smash the clot against the vessel wall, and then you place a metal scaffold.
The stent.
The stent, yes, to keep the artery permanently propped open.
It sounds like a fairly straightforward plumbing fix. But here's the conflict, and this is really the heart of our deep dive today.
Yeah.
You are introducing a foreign object,
Metal.
right, metal,
Mm-hmm.
and you are creating trauma in a blood vessel that is already in a state of absolute biochemical panic. The body is screaming, clot, clot, clot. If you just put a bare metal stent in there without any drugs, what happens?
Oh, it would be a total disaster.
Really?
The platelets would see that metal stent, they would recognize it as foreign, and they would attack it instantly. The stent would clot off what we call acute stent thrombosis, and the patient would likely die right there on the table.
So you essentially have to wage chemical warfare against the blood's ability to clot. You have to thin the blood.
You have to thin it aggressively. You need to paralyze the clotting system just enough to keep that stent open, but not so much that the patient bleeds to death from the puncture site in their groin.
It is a razor's edge.
It is terrifyingly delicate.
And in 2008, the standard way to walk that razor's edge was a combination of drugs that we might describe as, well, heavy artillery.
That is a very fair description. The gold standard at the time was unfractionated heparin paired with a class of drugs called glycoprotein IBO inhibitors.
Let's just call them GPIs to save our breath.
Good idea, GPIs.
So heparin and GPIs. This was the cocktail used in over 90% of primary PCI patients in the U.S. at the time.
Yeah.
Why was this the absolute go-to strategy?
Yeah.
What was the underlying logic?
The logic was simple: ischemia is the enemy. Ischemia means a lack of blood flow due to clots. Cardiologists were terrified of the clot.
And rightfully so.
Yeah.
Clots caused the heart attacks in the first place.
Exactly. The GPI drugs are incredibly powerful antiplatelet agents. Think of the platelet as having a final common pathway. No matter what chemical signal stimulates it, eventually it has to physically stick to other platelets to form a clot.
Right, it has to link up.
And it does this using a specific receptor called glycoprotein IBO.
Hence the name of the drug.
Right. These drugs essentially put a cap on that exact receptor.
It is like putting Teflon caps on Velcro hooks.
That is a perfect analogy. If you cap the hooks, the Velcro cannot stick. The platelets just bounce off each other. It is nearly 100% effective at preventing platelets from aggregating.
So the thinking was, if we shut down the platelets completely, the stent stays open and the patient lives.
Yes, it was a hammer approach. Smash the clot capability to zero? The sledgehammer?
And for years, the data actually supported this, right?
It did. Adding GPIs to heparin definitively reduced recurrent heart attacks compared to just using heparin alone. It became dogma. If you were not using GPIs, you were considered to be undertreating the patient. You were being negligent.
But, and this is the big, but that launched this massive Horizons AMI study, there was a dark side to the sledgehammer.
A very dark side. The source material highlights a critical insight regarding hemorrhagic complications. You see, while everyone was high-fiving about the open arteries, a totally different problem was creeping up in the data.
These patients were bleeding.
They were bleeding profusely.
And we aren't talking about a paper cut here.
No. We are talking about major bleeding. Bleeding at the access site in the groin, bleeding into the brain.
Wow.
And for a long time, the culture in cardiology treated this as just a nuisance, a side effect. Oh, the groin is oozing, just hold pressure for 20 minutes. Or their hemoglobin dropped, give them a blood transfusion.
It was seen as the cost of doing business.
Exactly.
Yeah.
The price of an open artery.
But the experts involved in this study, Dr. Stone and his massive team, they were looking at data that suggested something much more terrifying. Bleeding wasn't just a side effect, it was a killer.
That is the pivotal realization of this entire era. They noticed that if a patient had a major bleed, their risk of dying, both right there in the hospital and even a year later, skyrocketed.
It was an independent predictor of mortality.
Yes.
Let's dig into the why there, because it seems obvious that losing blood is bad, but why is it as bad as a heart attack?
It initiates a cascade of physiological disasters. First, if you bleed, you lose volume, your blood pressure drops, your heart, which is already struggling and damaged because of the heart attack, now has to work even harder with less oxygen fuel.
That makes sense. It's a supply and demand mismatch.
Exactly. Second, the treatment for bleeding is often to stop the blood thinners.
Oh, right.
So now you have a patient with a fresh metal stent, and you are forced to strip away their chemical protection against clots. You are caught completely between a rock and a hard place. Do you let them bleed, or do you let the stent clot?
And the source mentions blood transfusions specifically as being problematic, which is counterintuitive.
Yes, it is. You might think, well, they lost blood, just put new blood in. Problem solved. But blood transfusions are highly inflammatory. Transfused blood is not exactly the same as your own fresh blood.
Right. It's been stored.
It degrades. It can trigger massive immune responses, inflammation, and actually worsen the long-term outcomes for cardiac patients.
Plus, the source mentions a condition called thrombocytopenia.
Yes.
What exactly is that?
Thrombocytopenia simply means a low platelet count. The standard treatment, that heparin and GPI cocktail, can sometimes trigger the body to actively destroy its own platelets.
Like an autoimmune response.
Exactly. It is an immune reaction to the heparin. So you are trying to stop a clot, but the drug causes the patient's platelet count to crash so low that they literally cannot stop bleeding if they get a minor cut or internal shear stress. Thrombocytopenia is strongly associated with death in these specific patients.
Okay, so the status quo was, we have a sledgehammer. Heparin plus GPI. It is great at stopping clots, but it causes severe bleeding, and that bleeding is killing people. Enter the challenger. Bivalirudin.
Bivalirudin.
What is this drug? How is it fundamentally different from the chemical cocktail of heparin GPIs?
Bivalirudin is what we call a direct thrombin inhibitor.
Okay, let's break that down for the listener. How does a direct inhibitor differ from heparin?
Well, heparin is an indirect inhibitor. It is actually a bit messy pharmacologically. It does not work by itself. When you inject heparin, it has to find and bind to a specific protein in your body called antithrombin III.
Okay.
Once it binds, it supercharges that protein to stop clots. But because it relies on that middleman, its effects can be wildly unpredictable. It binds to other random proteins in the blood. It varies drastically from patient to patient.
So heparin is like sending a message through a game of telephone.
A little bit, yeah. You hope the message gets there intact, but it is sloppy.
Stop.
Bivalirudin, on the other hand, is a direct actor. It is actually a synthetic molecule derived from the saliva of medicinal leeches.
Wait, leeches?
Yes. Hirudin is the natural anticoagulant that leeches use to keep your blood flowing while they feed on you. Bivalirudin is a refined synthetic version of that.
That is wild.
It ignores the middleman entirely. It goes straight to thrombin, which is the key enzyme that creates fibrin, the glue of the blood clot, and it binds directly to it. It shuts it down point blank.
So it is a sniper rifle versus the sledgehammer.
Precisely. It is a highly precision tool. It has a very predictable effect. And crucially, it has a very short half-life. It goes in, does its specific job, and clears out of the body in about 25 minutes once you stop the IV drip.
And the source mentions that Bivalirudin wasn't brand new. It had seen some success before this trial.
Yes, it had been studied in the REPLACE-2 trial for patients with stable angina or milder heart attacks. In those less severe cases, it showed it could significantly reduce bleeding while maintaining overall safety against clots.
And this is the huge risk the study took. No one knew if it was strong enough for a full-blown STEMI.
Because the STEMI is the big one.
Yeah.
The body's clotting drive is ferocious.
Right.
The sheer amount of thrombin, the level of platelet activation in a STEMI, is just off the charts. There was a genuine and pervasive fear that if you use this gentler drug, Bivalirudin, without the GPI sledgehammer, the clot would just overwhelm it.
You might save the patient from bleeding out, but you lose the artery anyway.
Exactly. You trade one disaster for another.
That is the exact gap in knowledge that Horizon's AMI was designed to fill. So let's talk about the study design. How do they set up this massive showdown?
They went big. It was a prospective, open-label, randomized, multi-center trial. They recruited 3,602 patients across 11 countries.
I just want to pause on the sheer logistics of that for a second. We are talking about patients who are in the middle of a massive heart attack. They are in agonizing pain. They're terrified. Things are moving at light speed.
Yeah.
And the researchers have to get informed consent and randomize them right there.
It is arguably the most difficult type of clinical trial to run. You have a very narrow window, typically under 12 hours from symptom onset, to get them into the lab and open that artery. To insert a rigorous randomization protocol into that chaotic life-or-death environment requires incredible discipline and coordination across those 123 centers.
And what were the rules of engagement here? How are the patients divided up?
They were randomized 1-to-1. Group A, the control group, received the standard of care, that is unfractionated heparin, plus a glycoprotein PCI inhibitor.
The sledgehammer.
Right. And Group B, the experimental group, received Bivalirudin alone.
Bivalirudin alone. No GPIs at all.
That was the core strategy. Bivalirudin monotherapy. However, they did brilliantly allow for a safety valve in the protocol.
Okay, what was that?
If the doctor got into the procedure, deployed the stent, and saw a massive giant thrombus that simply wouldn't break up, Or if they had a phenomenon called no reflow, where the main artery is technically open but the blood isn't moving because the microscopic vessels downstream are clogged, the doctor was allowed to use a GPI as a rescue therapy.
That makes total sense. It is an ethical safeguard. You do not want to let a patient literally die on the table just for the sake of strict protocol adherence.
Exactly. You have to treat the patient first. And in the end, about 7.2% of the bivalirudin patients did end up getting a rescue GPI because things got ugly. But the vast majority, over 90%, were treated purely with bivalirudin alone.
And these two groups of patients were well matched.
Very well matched. Average age around about 76% male, 17% diabetic. A very standard representative STEMI population.
Oh, so we have the players, we have the rules, and we have the arena. Now we need to know what counts as winning. What were the endpoints they were measuring?
They had two primary endpoints. The first was pure safety, major bleeding. The second was a composite endpoint called Net Adverse Clinical Events, or NACE.
NACE. That is a term that comes up a lot in these major trials. Break that down for us.
NE is a way of looking at the total patient outcome. Historically, older trials looked at efficacy, the heart attack stop, and safety, did they bleed, completely separately. NE forces you to combine them.
Right.
It is major bleeding plus major adverse cardiovascular events. And those cardiovascular events include death, reinfarction, stroke, and stent thrombosis.
It is the ultimate balance sheet. Did we do more good than harm overall?
Exactly. If you stop the heart attack but you kill the patient with a catastrophic brain bleed, your NACE score is bad. If you stop the bleed but let the heart attack destroy the ventricle, your NACE score is bad. You need to win on the net clinical benefit.
Okay, let's get right to the results. The moment of truth. First up is bleeding. Did the challenger bivalirudin actually make a tangible difference?
It wasn't just a minor difference, it was an absolute landslide. The data showed that bivalirudin reduced major bleeding from 8.3% in the control group down to 4.9% in the bivalirudin group.
That is a massive drop, 8.3 to 4.9.
That represents a relative risk reduction of 40%.
Wow.
And the p-value was less than 0.001.
For you listening who might not be statisticians, translate p less than 0.001.
It basically means the probability of this specific result happening by random chance is less than 1 in 1,000. It is statistically rock solid. This was not a fluke of the data. This was a powerful real-world biological effect of the drug.
And the source details the specific types of bleeding too. We're not just talking about minor bruising on the arm.
No. They saw significant reductions in the need for blood transfusions. They saw less of that dangerous thrombocytopenia we discussed. And most importantly, they saw a huge drop in access site bleeding at the femoral artery in the groin where they inserted the catheters.
This connects right back to what you said earlier. If you stop the bleeding, you aren't just saving the patient from a longer, more annoying hospital stay. You were saving them from that entire cascade of physiological stress.
Which leads us directly to the most important finding of the entire study, the survival data.
This is the part that I think really shocked the medical community.
It absolutely did, because remember, the pervasive fear going in was that bivalirudin might be too weak. You save the bleeding, sure, but maybe you lose a few more patients to recurrent heart attacks. A grim trade-off.
Right, the whole cleaner sheets, but more damaged hearts idea.
That is exactly what they feared, but that is not what happened. When they looked at the net adverse clinical events, the SEE score, the bivalirudin group won hands down, 9.2% versus 12.1%.
As a clear win.
But when they looked specifically at mortality, bivalirudin actually saved more lives.
Let's look at those exact numbers.
Cardiac death was significantly lower in the bivalirudin group, 1.8% compared to 2.9% in the sledgehammer control group.
And all-cause death, meaning dying from anything at all, was also significantly lower, 2.1% versus 3.1%.
Wait, I really want to sit with that for a second. The drug that was intentionally less aggressive at blocking platelets resulted in significantly fewer deaths overall. That feels completely counterintuitive if you are operating under that old sledgehammer mindset.
It completely dismantled the dogma. The medical establishment had to swallow a new reality. The reduction in mortality wasn't because bivalirudin was somehow magically better at stopping clots. It wasn't. It was because it was better at preventing bleeding.
Can we definitively prove that link, though? Or is it just a really strong correlation?
The authors did a very clever post hoc analysis to prove it. They looked closely at what actually killed the patients who died in the study.
Okay, what did they find?
They found that more deaths occurred after a major bleed, 26 deaths, than after a reinfarction, only 10 deaths.
Read that again. That is the statistic of the deep dive for me. 26 deaths were directly linked to a bleeding event. Only 10 deaths were linked to having another heart attack.
That entirely flips the script. We spent decades terrified of the reinfarction wolf protecting the house with sledgehammers, and meanwhile, the bleeding bear was in the backyard eating the patients.
That is a very colorful but highly accurate way to put it. In the specific context of primary PCI for STEMI bleeding turned out to be the far more dangerous enemy. By using the sledgehammer, we were preventing those few extra reinfarction deaths, sure, but we were causing a massive chunk of those bleeding deaths. By switching to the sniper Bivalirudin, we stopped the bleeding, and the net result was far more survivors walking out of the hospital.
That is profoundly shifting. It really forces you to rethink the foundational phrase of medicine. First, do no harm. Sometimes the treatment that feels the most robust, the most protective, is actually doing the most harm.
Precisely. However...
I knew it. There is always a however in these massive trials. No clinical trial is perfect, and this story has a major plot twist.
It does. And honestly, it is a twist that kept a lot of cardiologists up at night for years after this was published. We talked about how Bivalirudin is a precision tool that wears off quickly.
Right. 25 minutes after the IV stops and it is gone.
Well, there was a severe downside to that rapid clearance. Within the first 24 hours after the procedure, the Bivalirudin group had a noticeably higher rate of acute stent thrombosis.
Stent thrombosis. We defined this earlier. That means the stent, the life-saving metal scaffold, they just put in clots up completely.
It shuts down. Imagine the clinical scenario. You have rushed the patient to the lab.
Yeah.
You have opened the artery. The blood flow looks perfect on the screen. The patient's chest pain is gone. High fives all around the room. The patient goes up to the recovery room or the cardiac care unit.
Okay.
And then 2 hours later, the alarm bells go off. The chest pain is back. The ECG changes again. The artery is clotted entirely shut.
That is literally the nightmare scenario. What were the numbers on that?
In the Bivalirudin group, the rate of acute stent thrombosis in that first day was 1.3%. In the control group with the sledgehammer, it was only 0.3%.
That is a massive relative difference. 1.3% is more than 4 times higher than 0.3%.
Statistically, it was highly significant. P less than 0.001 again. It was a very real phenomenon. The Bivalirudin group was objectively more vulnerable in that first day.
Why? Physiologically, why did this happen?
It goes right back to the pharmacology and the timeline of the drugs. When a patient gets a stent, they are also given oral antiplatelet pills to take long-term. In 2008, the standard pill was clopidogrel, also known as Plavix.
Okay.
But clopidogrel is what we call a prodrug. It is totally inactive in the pill form. You swallow it, it goes to your stomach, gets absorbed, goes to the liver, and the liver has to actively metabolize it into the chemical form that actually works.
And then it takes time.
It takes hours to reach therapeutic protective levels in the blood.
And meanwhile, the Bivalirudin.
Bivalirudin is an IV drug. You turn the pump off at the end of the procedure. 25 minutes later, it has completely left the building.
I see the problem. You have a gap.
Exactly. You have a critical window of vulnerability. The Bivalirudin is gone, but the clopidogrel hasn't clocked in for work yet. In that gap, the angry platelets see the fresh metal of the stent, and because there is no drug suppressing them, they attack. This is the adenosine diphosphate-induced platelet activation that the source specifically mentions.
And the heparin and GPI group didn't have this problem.
No, because GPIs linger. They physically stick to the platelets for hours, sometimes even days. They provided a continuous chemical bridge covering that dangerous gap until the oral pills finally kicked in.
So it's a very clear, very stark trade-off. Bivalirudin saves you from bleeding to death, but it gives you a roughly 1% higher risk of your stent clotting up in the first 24 hours. That sounds like an incredibly tough gamble to explain to a patient, hey, I can give you the drug that makes you bleed less, but your heart attack might come back tonight.
It sounds terrifying on paper. But the real clinical question is, did it matter in the long run? Did that 1% spike in early stent thrombosis translate to more death?
That is the ultimate question. Did they survive the trade-off?
The answer is emphatically no. It did not lead to more deaths. When the researchers looked at the 30-day data, the overall rates of stent thrombosis between the two groups completely equalized. There was no significant difference overall by the end of the month.
Wow, okay.
And when they looked at the mortality impact, Only 2 deaths in the entire study out of 3,602 patients were linked to this acute stent thrombosis.
2 deaths.
Just 2. One in the bivalirudin group and one in the control group.
Wait, so even though the stent clotting happened way more often with bivalirudin, it didn't actually kill the patients?
Correct. Because think about where the patient is when it happens. They are already in the hospital. They are hooked up to monitors. If the chest pain comes back, the nursing team recognizes it immediately. They rush them right back down to the cath lab, pass a wire balloon again, and fix it.
It is a fixable problem.
It is a morbid event. It is scary. It involves another invasive procedure, but it is highly salvageable.
Whereas a massive internal retroperitoneal hemorrhage from the sledgehammer
Is much, much harder to fix. Once that clotting cascade is fundamentally broken and the patient is bleeding internally into their abdomen or brain, it is notoriously difficult to stop. You cannot just reopen a brain bleed the way you reopen a stent.
So the study firmly concludes that the trade-off is absolutely worth it. You accept a 1% risk of a highly fixable problem, the stent thrombosis, to gain a massive reduction in a highly fatal problem, the bleeding.
That is the bottom line. And that specific math results in a 1% absolute reduction in overall cardiac death. In the world of massive clinical trials, saving 1 additional life for every 100 patients treated is a total home run. It is incredible clinical leverage.
Let's move to the discussion and clinical implications of this. Because this study didn't just change a hospital drug protocol, it challenged the entire medical philosophy of the time.
It really did. Before this, the pervasive dogma was more anticoagulation is always better. If the artery is blocked, blast it open with everything you have. This study forcibly shifted the focus to net clinical benefit.
Right.
It forced cardiologists to balance ischemia prevention with bleeding prevention. It moved us from a pure warrior mindset where you just destroy the clot at all costs to a guardian mindset where you protect the whole patient.
And did the results hold up across different types of patients? Like, did it work for everyone?
Yes, they did extensive subgroup analysis. It didn't matter if the patient was old or young diabetic or not. It didn't even matter if they had already received heparin in the ambulance before arriving at the hospital. The core benefit of switching to bivalirudin held up across the board.
Now we have to address the limitations. The expert in you must have some critiques of how this was run.
Always. You always have to look at the flaws. The biggest critique of this trial, by far, is the open-label design. We touched on this briefly. The doctors knew exactly which drug the patient was getting. It wasn't double-blind.
Why does that matter so much in a trial like this?
Well, bias creates statistical noise. If I am the doctor and I know my patient is on the quote-unquote weaker drug bivalirudin, I might be way more nervous. I might react aggressively to a minor change in the ECG that I would normally ignore. Or conversely, if I know they are on the strong drug, the GPIs, I might be hypervigilant about checking their groin for bleeding. It introduces human behavioral changes into the raw data.
But could that bias really fake a reduction in actual death?
That is the key defense of the study. Death is a hard endpoint. You are either dead or you aren't. Bias does not change a death certificate.
That is a fair point.
And major bleeding, which they strictly defined as a massive hemoglobin drop of 4 grams, or a literal intracranial hemorrhage that is very hard to fake or subjectively misinterpret too. So while open label is definitely a limitation, the robustness of those hard endpoints makes the data incredibly credible.
Also, the fact that they allowed rescue use of GPIs actually reflects real life, doesn't it?
Exactly. It wasn't an artificial, sterile lab condition. It mirrored gritty, real-world practice. It basically told doctors, start with the safer drug. If you get into deep trouble, the heavy artillery is still right there on the shelf. Just don't start with the heavy stuff by default.
What about the future? The authors specifically speculate about that gap, the 24-hour window where the stent thrombosis happened. They suggest that maybe we just need better oral drugs.
That is a very prescient part of their discussion. They correctly identified that the clopidogrel pill was the weak link because it was just too slow to metabolize. They suggested that more potent, faster-acting oral antiplatelets could solve the entire problem.
And did they? I mean, sitting here today, did that happen?
They absolutely did. Drugs like prasugrel and later ticagrelor were developed and approved. These drugs kick in much faster and are far more potent than clopidogrel. So in the years following this study, the field moved heavily toward using those newer oral drugs. This effectively closed the gap, allowing us to use bivalirudin for its amazing safety profile while fully protecting the stent right away with better oral meds.
So Horizon's AME really was the pivot point. It identified the core problem, bleeding is deadly. It proved the solution bivalirudin, and it even pointed the way toward future optimization with better oral drugs.
It was arguably the study that matured the entire field of interventional cardiology. We finally went from using blunt instruments to practicing precision medicine.
It is a fascinating case study in how medical progress isn't always about finding a stronger drug. Sometimes it is about finding a smarter one, or just realizing that the side effects we tolerated as normal for years were actually killing the very people we were trying to save.
It is a massive lesson in medical humility. We have to constantly audit our gold standards. Just because we have done it one way for 10 years and it feels right does not mean it is actually the best way.
So let's summarize this deep dive with our funnel analogy to tie it all together.
Right. Imagine a giant funnel. At the top, you pour in a massive population of high-risk heart attack patients. You have two distinct pathways to send them down.
Pathway 1 is the sledgehammer. Heparin and GPIs. It crushes the clots mercilessly. The stents stay wide open. But a significant number of patients slide down a side chute labeled major bleeding. And at the bottom of that bleeding chute, many of them just don't make it.
Pathway 2 is the precision tool, Bivalirudin. It stops the bleeding almost entirely. It closes off that major bleeding chute by nearly half. However, there is a small, treacherous trapdoor in the first 24 hours called acute stent thrombosis.
But the data definitively shows that even with that scary trapdoor, because it is largely a fixable mechanical problem, Pathway 2 delivers significantly more living, breathing patients safely out the bottom of the funnel.
That is the pure essence of Horizon's AMA. It proved mathematically that in the calculus of survival, preventing the bleed is just as important as stopping the clot.
It is an incredibly powerful lesson. And it leaves us with a final provocative thought for you, the listener, to mull over.
Consider the foundational principle, first, do no harm. In modern medicine, we have incredible, almost science fiction technology. We can snake tiny catheters into beating hearts. We can dissolve solid clots. We can deploy metal stents inside tiny arteries. But this study rigorously reminds us that the human body is a delicate, interconnected balance. Sometimes the most aggressive, heroic treatment is actually the enemy of the best outcome.
If bleeding is a stronger predictor of death than a recurrent heart attack, how does that change not just emergency medicine, but how we think about risk in general? Are we sometimes so hyper-focused on the obvious enemy in front of us, the clot, that we completely miss the deadlier enemy we're actively creating, the bleed?
It is a vital question worth mulling over. Are we actually solving the problem, or are we just changing the way the system inevitably fails?
A huge thank you to the researchers, the brave patients, and the global institutions involved in this massive, massive study. It is a story of nuance, rigorous data, and ultimately saving countless lives.
It certainly is.
Thank you for watching The Funnel Effect.